Hello, hello. We want to welcome everyone to the second presentation in our AIMS quarterly webinar series titled Sharing the Responsibilities of the Behavioral Healthcare Manager Role in the Collaborative Care Model. Our goal with this webinar series is to highlight the work of practices that are using the collaborative care model and to share real life experiences and best practices around this work that we're all doing. I am Monica Williams Harrison with the AIMS Center. I'm joined today by my AIMS Center colleagues, Sarah Barker and Christy Malmstrom. The AIMS Center helps support organizations implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. The purpose of the AIMS Center is to inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call today is being recorded, and we'll be sending out a link to the recording and the slide deck to everyone who registered. This webinar format accommodates our large audience today, which is exciting. And you'll see on your Zoom screen that there is a Q&A function. We're asking you to use that instead of the chat box. You can enter your questions for the presenters at any time, but we'll only answer the questions after all presenters are concluded. Today, we'd like you to focus your questions on the experiences of these expert presenters. And if you have general questions about implementation or financing collaborative care, please bring those to our implementation or financing office hours. You can also check out our FAQ on our website. Sarah's putting the links to both of those in the chat for you so that you can have it. At the end of this session today, participants should be able to understand how the behavioral health care manager responsibilities are shared across a variety of clinical settings and organizations, describe the benefits and challenges of having extended team members provide shared collaborative care model responsibilities, and identify resources available to help them with implementation of the behavioral health care manager role. I'm going to start by quickly running us through the basics of the behavioral health care manager role. One thing of note is I'm using the Medicare guidelines with the next couple of slides I'll be talking about, but keep in mind that some commercial payers and your state Medicaid plans might follow slightly different rules and have different expectations. So you want to make sure you check with your organization's contracts on that. So there are 5 key principles that have been identified to drive effective collaborative care. So the first is patient-centered team. So the patient, primary care, and mental health providers collaborate effectively using a shared care plans and incorporating patient goals. The second is population-based. A registry is used to facilitate engagement and outcome tracking in a defined group of patients at the caseload and clinic level. Then 3 is measurement-based treatment to target. Progress is measured regularly and treatments are actively changed until clinical goals are achieved. The 4th is evidence-based treatments. Providers use treatments that have research evidence for effectiveness. And the first 4 principles lay out the foundation for the 5th principle, which is accountable. This means the care team is accountable to the patient and other care team members for quality of care and clinical outcomes, not just the volume of care that's provided. Discussion of the care team is what brings us all together today. Here is the care team structure that incorporates the patient, a primary care provider, the psychiatric consultant, a registry, and the behavioral health care manager. The behavioral health care manager has 2 important sets of tasks to support the delivery of collaborative care treatment. The first set of tasks falls under the category of general behavioral health care management or care coordination functions. The second set of tasks is specific to providing evidence-based brief behavioral interventions for the patient if that's a part of the patient's treatment plan. Because of the nature of these tasks, typical licensures that are most appropriate for this work include master's level social workers, master's level counselors, licensed professional counselors, nurses, and those with advanced degrees in clinical psychology. We recognize that there's a whole host of individuals that have other disciplines that are being utilized as well. Depending on the care manager's licensure and the state in which they work, there may be considerations around what tasks are within the scope of practice for the care manager, which has further implications for billing and for reimbursement that are tied to licensure. As I mentioned, the first set of tasks for the behavioral health care manager falls under the category of general care management functions. The primary focus here is to help the team track and coordinate the care being provided for the patient. The care manager owns the caseload of patients and coordinates the shared treatment plans between the other members of the team. Care managers facilitate patient engagement, perform systematic initial information gathering, as well as track treatment over time and support the treatment plan in terms of helping the patient stay engaged with the primary care provider, while also at times providing behavioral interventions. Typically, the care manager is also the person working with the psychiatric consultant in weekly caseload review, bringing patients who are not improving up for consultation. It's important to state collaborative care is also very effective for patients who have medication as their sole treatment plan, because the care management functions have been proven in dozens of research studies to result in more patients getting better faster than if they don't receive care management. The complementary set of tasks to general care management involves providing evidence-based brief behavioral interventions. Providing behavioral treatment in a primary care setting is an important strategy to intensify care when needed. Common interventions that are appropriate include behavioral activation, problem-solving treatment, cognitive behavioral therapy, other treatments with research evidence that support their efficacy. Therapy is not a prerequisite to enrolling a patient in collaborative care. Does not require, collaborative care doesn't require that a patient be involved in counseling. Patients benefit from collaborative care management regardless of whether they want and have counseling as a part of their treatment plan. This is why today's topic is relevant. Since we know that care management functions beyond therapy are important, there are health systems that include additional staff to support the behavioral health care manager role with some of the functions that don't require licensure. Thus, having staff share the behavioral health care manager duties or responsibility, along with documentation and communication with the entire team. We invited all of today's presenters because they have embarked on innovative ways to support the behavioral health care manager role. I'll let each of them introduce themselves when they speak. With that, we're going to get started and kick it off with our first presenters from Kittitas Valley Health.
Thank you, Monica. Good morning. I'm Elisa Peterson. I'm an MSW, and I am the Behavioral Health Care Manager here at Family Medicine of Cle Elum, also part of Kittitas Valley Healthcare. We are a rural clinic based in Cle Elum, Washington. We have 5 medical providers. We have an on-site medically assisted treatment program, 1 psychiatric consultant, and 1 behavioral health care manager. And our program is innovative because we've incorporated 1 designated medical assistant. As a behavioral health care manager, my caseload averages 75 patients. And I serve patients of all ages and insurance types. Medicare and Medicaid make up at least 50% of our caseload at any given time. And our patients are primarily Caucasian, Native American, and Hispanic. So when we were thinking of having collaborative care at our clinic, we modeled our program and included an MA in our program based on a few things. The first is that previous to having collaborative care, our psychiatric consultant found a lot of difficulty and time burden managing all the tasks of serving our patients. So those time burdens include phone calls, portal messages, answering inbox messages, scheduling appointments. We also wanted to provide excellent internal and external customer service for our patients. And the last thing was to improve our no-show rate. And now Marcella is going to talk us through our workflow at our clinic.
Hi, I'm Marcella. I'm the medical assistant for behavior health. The workflow here at our clinic is that the behavioral health care manager or the medical assistant conducts a warm handoff at the request of a primary care physician. The medical assistant then contacts the patient to schedule their initial appointment. If not able to contact the patient, a detailed letter is sent to them with instructions to go ahead and schedule their appointment. The MA confirms the schedule the day before. This involves personally calling patients in addition to the automated reminder text or phone calls they receive from the clinic. Zoom links are sent out one day prior to appointments if a Zoom is scheduled. Cancellation appointments are then filled at this time from the standby list. The check-in process is the PSR gives the paperwork to the patient upon arrival. The medical assistant rooms the patient, which includes obtaining vitals and review of medications. The PHQ-9 and GAD-7 are also entered into the chart at this time. Check-in for Zoom appointments. The MA calls the patient on the phone prior to the appointment and completes the PHQ-9 and the GAD-7 into the chart. Any technical issues are also resolved during this time. After the appointment, the medical assistant is then notified by the provider when the follow-up appointment is due. If unable to contact the patient to schedule that follow-up appointment, once again, a reminder letter is sent to the patient, including all of that information. The clinical inbox is continuously monitored through the day, throughout the day by the medical assistant with patient phone calls and medication refill requests. The medical assistant also completes prior authorizations for medications and also appeals for denials. Who is involved? The PSR, the MA, referral coordinator, clinic MAs if I am out of the office. All clinic MAs are also trained for the collaborative care workflow. What tools do we use? The forms include a review of systems, PHQ-9, GAD-7, and mood disorder. Our electronic medical records include use of Cerner, revenue cycle for scheduling, which also includes the standby list, Zoom, and the AIMS tracker. We use a variety of letters if unable to contact the patients, including the follow-up reminder letters, no-show appointment letters, unable to contact the patient for initial appointments, and also inactive patient letters. How the workflow assists in meeting the diverse needs and population. The reminder calls decrease the number of no-shows. During this time, it's also an opportunity for the medical assistant to schedule a patient that is in crisis. This establishes patient relationships that allow for the medical assistant to know patient strengths, needs, preferences, and abilities. Medical assistant assists with transportation arrangements if needed. MA functions as care coordinator between PCP, behavioral health care manager, and PC, facilitating follow-up appointments with a primary care physician or address any questions if appropriate.
So one of the main ways we communicate in our clinic is by recording our activities in the electronic health record. The MA enters the validated measures into the electronic health record, and the behavioral healthcare manager charts in the healthcare record, but also enters all data into the AIMS caseload tracker. In addition, all treatment planning is documented in the EHR. And the shared electronic health record among our entire team is Cerner. And then we have a billing department that audits for quality and will let us know if something's missing for our bill to go through. So the benefits and drawbacks of having an MA. Having an MA working with our program definitely improves patient compliance with follow-up appointments, and it improves clinic flow and really maximizes the time providers have with patients. We have not noticed any drawbacks. So I think sometimes the idea of cost comes up, but the cost of having Marcella as an MA definitely makes itself up with our increased productivity.
Lessons learned: having a designated medical assistant is essential for our program for fewer no-shows and patient satisfaction. This also allows for efficient documentation of PHQ-9 and the GAD-7, as the medical assistant does enter them on every patient that we see. Improve productivity with behavior healthcare manager, overall less burnout for our team. Improve coordination with primary care physician, better provider patient satisfaction. MA also serves as a gatekeeper, fielding calls and checking messages in the patient portal.
Great. Next up for our organization is Prisma Health.
Hey, good afternoon. I'm Jessica Anderson. I am the manager for the behavioral health program here at Prisma Health. Alongside with me is one of our behavioral health caseworkers, Jessica Lord. So we'll be presenting what we do through Prisma Health, which is located in South Carolina. And so just a little bit about our organization. Prisma Health really kind of oversees patient care mainly in our upstate and Midlands area. So you can see that on our map, the green and blue. We also have part within our department, which is care management. We are part of the NVO network. So our team is also part of the accountable care community work that we do. So we go beyond Prisma Health for other areas. Currently, collaborative care is mainly within our Prisma Health practices, but we serve through this network over 298 physician practices. We have about 1,815 employed physicians. That doesn't include other providers. So if you look at nurse practitioners and PAs and those other providers, we have over 5,000 within our integrated care network. We serve 22 counties at this time through our organization. Specifically for collaborative care, we are located within 10 of our practice locations, 8 of those being in our upstate, which is where we started the pilot program many years ago. I say many, but about 2016 through 2017. And then we recently added 2 practices in our Midlands area. So we are continuing to expand our services. One of the things that we do to leverage our team is we don't have one-to-one assignments with our care managers or our caseworkers. So our caseworkers are really who support this program administratively and clinically for the programs. But we have 5 behavioral health care managers with various licensures for various programs. So we have licensed professional counselors, marriage and family therapists, social workers, LISW, CPs, and usually for our care managers, they serve between 2 to 3 practices is what they're assigned to, and that's really kind of based on the size of the practice. We have some that have about 5 or 6 providers, and we have some that have 2 or 3. So just kind of based on the volumes of what they need is how they serve. And then we have 3 behavioral health caseworkers that support our upstate clinics. So they're usually assigned between 2 or 3 practices themselves. For our care managers, our average caseload usually runs between 50 to 60 patients, and that's kind of determined based on if they're new and they're ramping up, if they've been around for a while, if it's a new practice or an established practice. So there's a lot of variables there. And then usually for us, like I mentioned, our practices have between 3 to 6 providers with doctors, APPs, and PAs. And so one of the things that we looked at as to why we wanted to add a caseworker to help with the care managers is that when we piloted our program, we used current outpatient therapists. So me and my team, we were actually part of the Department of Psychiatry at the time. We recently, probably 3 years ago, moved into the care management department. But because of that, these outpatient therapists already had a caseload of patients in their outpatient practice. And so when we piloted the program, we used 2 practices, 2 family medicine practices in the upstate. And each care manager had a half a day a week to start in those practices. So you can imagine only having, about 4 hours in a day. If you're having to do all of the required elements of collaborative care, you're not going to be seeing a whole lot of patients. And we really wanted our therapists to see as many patients and do the clinical care versus having to try to, maintain the registries and appointments and reviewing referrals and supporting, that other administrative work that they have to do. So we created the behavioral health caseworker position. And what that did is it brought in a level of staff that usually have their bachelor's in some kind of psychology or human services program. And they also had, for most of my team, some behavioral health background. So many were either currently doing activities and duties within a psychiatric department, or they were doing caseworker duties out into some of the programs and doing some care management there. The other thing, the reason why we did that is for most of our practices, the staffing's pretty tight. So as we went into practices, one of their main concerns was, I don't really have anybody that I can pull to give extra duties to because they have limited staffing themselves. And so one of the things we did was to try to help to create a position that would not only support the behavioral health team within collaborative care, but also the practice and give that pressure release off of them of having to try to do all of that stuff too, because we really did want our care managers to really solely work around the clinical piece of care and try to get that off to someone else. So in doing that, our workflow, I'm going to give this to Jessica Lord so she can talk a little bit about the workflow that we do currently that our caseworkers do.
Hi, my name is Jessica Lord, and I am one of the caseworkers within our collaborative care program. And as Jessica mentioned, what we really like to do, or what we do, is do whatever we can in our program to allow the care managers to see as many patients as they can, and not allow patients to fall through the cracks. So the caseworkers will universally screen the patients for depression through using the BHCM, or for anxiety through the GAD-7. We will process referrals that come from the primary care providers into our work queue, and call the patients to schedule their appointment, do a pre-initial to get the depression anxiety scores, and any background information that we can get that will be provided to the behavioral health care manager to allow them to really work through their assessments that they do. We also provide warm connections in the office. So if a primary care provider has a patient that they're currently seeing at that moment within the practice, then they could come to our caseworker, where we could go into the room with that patient and tell them about the collaborative care program, what it entails, the billing cost that comes with it, as well as schedule their appointment right then and there. We perform a lot of chart reviews. call patients to reschedule, or if they no-show, just making sure that nobody falls through the cracks, as well as if there's any patients that are not eligible to be in collaborative care within our program, we help those providers and those patients find outside resources and get them connected to somebody outside of our program so that they have what they need and don't fall through the cracks, even if they're not with us. We also complete the billing services for our practice that we're in, as well as allowing, informing those patients who are not covered where they can get their services from. And then I think Jessica goes back to you.
Sure. So thank you, Jessica. I know that's kind of confusing. We're both Jessica. So recording of the collaborative care activities in our EHR. So we use Epic. We have created and developed things, smart phrases, flow sheets, and templates to help us with our documentation. So treating providers, we give them smart phrases. We add them to it to help to prompt them on, consent for patients when they're identifying patients. We use templates to flow information in from multiple areas of the chart, so we can help with not having to duplicate documentation. We also, back in 2022 or 2021, we built out in Healthy Planet, which is part of Epic, our registry. So one of the things that we really try to look at is how we can move a lot of the manual documentation out of spreadsheets and actually track them within our EHR. And so our registry currently, we're able to track all of our patients, their status, whether they're active, relapse prevention, or inactive. We're able to track their screening scores, able to identify areas on the patient, such as who their treating provider is, their care manager, their psychiatric consultant, so who their care team is. We also use encounter notes and progress notes to route and flow information back and forth between our team members and the treating providers. And one of the great things that we love about Epic is that it gives everybody on our team and the practice access to those records of the patient, so that there's a continuity of care that goes across without having to use time of staff to share that information. And then we also use our EHR to track and pull reports. Such things such as cancellation reports and no-shows, referrals, week quality metrics, billing sheets, so the time for billing, and that helps our team to know what patients they need to be paying attention to. And then some of the things that we look at, what are the benefits and drawbacks? Just as our previous group mentioned, there's more benefits than there are drawbacks to the program. It really does allow our care managers to utilize most of their time in clinical care of their patients. It allows the practice to actually have additional support without having to hire a full-time person. So our practices, it's a cost share for team members. It also allows our collaborative care team members to work closely together so that they can help to make sure that patient care is provided and that patients are getting what they're needing. It gives our treating providers and our practices access to the team, so they can email us, message us through Epic, send messages about questions about patient care or any kind of support that they need. The only really big drawback that we probably have with anything is because we're in multiple practices, we're not always on site when there's a patient need. And when we get referrals, our caseworkers, it can delay that kind of first touch with the patient. So sometimes just trying to track the patient down after they leave the office to talk about the program and to get them scheduled with the care manager.
Thank you so much. Next organization up is Kaiser Permanente.
Well, hello, everyone. My name is Elisa Onskol. I am a clinical quality consultant overseeing the administrative side, or what we like to say, the nuts and bolts of the collaborative care program. And I am here with one of our amazing staff members who is in a shared care manager role. Here in Kaiser Southern Cal, we call this role our population management support coordinator. This role is very unique under our population care departments. And we have a large amount of support coordinators supporting different chronic conditions like diabetes, osteoporosis, just to name a couple, and of course, collaborative care. So I'll go ahead and jump right in. Here in Kaiser Southern Cal, we have 13 medical centers with one collaborative care team at each center dedicated to that service area. Team sizes may vary depending on population or demand. However, each team does have at least one support coordinator supporting the team. Our depression population is in total approximately 405,000 patients. That does include our anxiety patients as well. In the past 5 years, our collaborative care program has treated approximately 50,000 patients and have maintained great remission and response rates over the years. Each care manager has an average caseload of about 120 per care manager at any given time. Our care managers, we currently have LCSWs, advanced practice providers who are RNPs and PAs. And so within our program, we have a specific criteria of which patients may benefit from our services. So this includes patients who are diagnosed with depression, major depression, generalized anxiety disorder, adjustment disorder, grief reaction, or persistent depressive disorder or dysthymia. Patients to mild to moderate symptoms of depression or anxiety, so with a PHQ-9 of 5 to 19, patients with a GAD-7 of score of 5 to 17, pregnant and postpartum women, patients undergoing cancer treatment, patients with history of substance use disorder or eating disorders that have been in remission for at least 3 months, and patients with a history of stroke and or mild cognitive impairment. Okay, next slide. So in Kaiser Southern Cal, we've been doing collaborative care for quite some time, and we were included in the impact study back in, I'm going to say 2002, and correct me if I'm wrong, Monica. But we've learned along the way after many years that one person doing it all, treatment, screening, follow-up, scheduling appointments, outreach, is not sustainable, just especially in a large organization such as Kaiser with such a large depression population as well. And what we learned and led us to our redesign of the program back in 2016 was that administrative tasks take away from treating the patient. And I think we can all agree on that. And there's definitely a higher chance of provider burnout. So I'm going to pass it over to Rosemary, again, one of our amazing support coordinators, to describe briefly on what her days consist of and how her role contributes to the success of the team.
Hi, my name is Rose, and I'm the support coordinator at the Downey Medical Office here at Kaiser. And as support coordinators, we maintain team structure and organization. We do this by helping to process referrals and determine patient eligibility for our programs. And if needed, we can transfer patients to a higher level of care like psychiatry. Once the patients are enrolled, we manage them through various patient lists and to ensure that patients are engaged in the program, that they're keeping their appointments and regularly screened for progress. And once they are discharged, that they're still in remission several months later. And then if needed, we can enroll them at that time if they're experiencing a new episode.
Great, thank you, Rosemary. So you'll see on this side our workflow. Members are identified for collaborative care through many channels. So of course, our benefit of our integrated care delivery system is that primary care clinicians are connected with mental health resources, collaborative care being one of them. And one way members can make it to the collaborative care is that they are referred through their primary care physician or specialty department. So if they feel that the member will benefit for the program. If a member has not gotten a referral for the program, there are multiple ways a team member from collaborative care will identify a patient and outreach to determine for eligibility for the program. So the teams have access to generate local lists for patients who are newly diagnosed with depression. These lists include member information like last PHQ-9 scores, medication information, last visit information. We also have PHQ-9s that are prompted by our decision support tools in our Epic platform. But in any case, once a team member from collaborative care gets any patient, whether it be by referral or patient list, those patients are contacted and reviewed for eligibility for collaborative care or other options such as our Center for Healthy Living option, which may be more suitable for patients who are lower acuity and looking for wellness classes, stress management, couples communication webinars, or to psychiatry where more specialized care for severe depression or other forms of trauma can be treated. but these options are discussed with patients and patients can decide what's best suited for them. Patients who then decide that they want to start treatment with collaborative care are then enrolled in collaborative care and will start with treatment with a care manager. And during the course of treatment, the support coordinator will assist with patient engagement by following up, doing a PHQ-9, GAD-7, rescheduling appointments if needed, reminding patients of appointments. We do have a registry to track all of our patients who are enrolled in treatment and discharged. So once the patients are discharged from the program, again, like Rose mentioned, she will make multiple attempts to check for maintenance of treatment effects and rescreen the patients with PHQ-9s. If the patients score high in relapses, the support coordinator will re-enroll into the program. So aside from their main task in assisting with engagement of patients with reminder calls and rescreening and re-enrollment, a support coordinator also acts as a patient resource and contributes to overall health and patient outcomes. So I'll pass it over to Rose again to elaborate more on this.
So support coordinators are very vital to successful outcomes for our patients because we support them both in and outside of the program. So while in the program, like Lisa mentioned in our workflow, we can spend that extra time helping them sign up for the educational classes that we offer at our Center of Healthy Living, as well as downloading online-based apps like Calm, as well as MyStrength to support their treatment in the program. And then outside of the program, one of the ways that we can support them is by applying for financial assistance that Kaiser offers, and that can help ease some of that burden for them. Another way that we're beneficial is by developing a rapport with patients. So some of the patients who are unsure about enrolling into our program, we can check in with them periodically and encourage them to enroll once they're ready. And then finally, patients who are not engaged or non-responsive, we can spend a little extra time to get them enrolled and benefit from our program. So with the many moving parts of our program, it's important that we document accurately and efficiently. Just like Prisma Care, we use Epic for our electronic health record. And in Epic, we have a flow sheet which we attach to all of our encounters, and it includes specific fields to document outreach attempts and patient interactions, and this ensures a standardized documentation at each touch. Ways that we prevent miscommunication between the team is by utilizing a feature in Epic called a sticky note, and it appears at the top of a patient's chart, and everyone on the team can see this easily once they open a chart. And here we include important patient preferences and in our appointment notes, we can document things that have been completed, like reminders, tech checks for video visits, and any specific requests that the patient or provider might have. Another thing we have are smart phrases, and this makes it easy to standardize our documentation across the team. We use a dot phrase, and that will automatically populate things like notes or letters or emails. And if a change is made to the dot phrase, then the entire team will immediately have access to that updated information to use. Another way that we communicate is by routing charts or sending staff messages to teammates, or we can send it to a pool that everyone has access to. All of this is managed in an in-basket that the team uses daily. And finally, we have shared lists for each of our medical centers. And this is a way to confirm that patients are enrolled and screened appropriately. It's a great way to cross-check that the documentation is recorded accurately in Epic.
Okay, thanks, Rose. So as you can see here, our benefits outweigh any drawbacks. So for Southern Cal, we had the opportunity to take our learnings from the inception of the impact study to where we are at now. Adding a support coordinator has proven to improve employee satisfaction, assist with possible provider burnout, providing quality across the continuum of care, access to care, promote standardization, boost team morale. I think this is a big one. Because sometimes when it's just one care manager, it can get lonely and overwhelming. And when you have a team, whether it be just two or three people, you gain that support and team building that allows that space for motivation and growth. And it's overall better for the patient and for all our staff members. And lastly, multiple points of contact. Patients have access to the team with more than one person. For our drawbacks, we came up with one. And that is a duplication of efforts. And Rose, did you want to maybe touch up a little bit on this piece?
Yeah, so at our medical centers, a lot of them have multiple support coordinators. So this can cause duplication of efforts, especially when outreaching to patients. So like our previous slide, it's very important to document accurately and have open communication within the team, as well as reviewing the chart at each point of or at each outreach, so that we can make sure there's less of that overlap.
Great, thank you. So after many years of trial and learning, we identified some key takeaways in making this supportive role successful. Identify roles and responsibilities, creating those and developing clear job aids and standardized workflows to prevent miscommunication amongst the team. Empowerment, encouraging your staff to provide feedback and input, promoting idea sharing amongst the team, really involving your staff when creating these workflows. I found this very impactful, as these are the people doing the work. We learn so much from them. So it really empowers them when they're involved in the process and gives them a real sense of being part of the team rather than just being told what to do. Training and education, engaging staff in shared learning webinars. So just like this, we have learning webinars scheduled every month. And this is where staff from different medical centers come together and can discuss difficult cases for consultation, or there could be topics of interest. Like, for example, we had the day in the life of a support coordinator. And we had that in the past where support coordinators are able to learn tips and tricks that other support coordinators and really share each other's experiences and giving them that space to have these conversations. And educational resources. We do have all of our support coordinators take motivational interviewing training, which is provided by our health education department. And again, team dynamics and encouraging communication to help support each other as needed. Just like Rose said, they schedule weekly and monthly team meetings to check in with each other, kind of help keep each other afloat. Rose, did you want to add anything else to this slide?
Yeah, just like Elisa said, it's important to have these huddles as well as meetings. And at our medical center specifically, we have a huddle every week as well as a monthly meeting. And this just creates a space to have discussions and adjust workflows. We can give feedback of what's working, what isn't working, any best practices that we have. And then especially those weekly huddles are great for goal setting for the week. If anyone's out of the office, we can reorganize and our efforts and achieve those goals. And obviously it's also a way to connect, since sometimes people might be in different offices or buildings, and it's just a way to encourage each other and remind each other that we're there for each other so that we can succeed together.
Thanks, Rose. So that concludes our presentation. I'll go ahead and pass it back to Monica.
Thank you. Well, many thanks to all of our presenters. It's so valuable to hear from those who are stepping up to figure out all of this and willing to share their learning experience with all of us. So some quick considerations before we go into the Q&A portion of the webinar today. So don't forget to put your questions in that spot of Q&A. The behavioral health care manager still owns the caseload of patients and the responsibility to make sure that the care plan is created and implemented. And as you've heard from all of the organizations, the importance of dividing up what those tasks and parts of the role will be and having clear communication between all of the team members and their different roles is really necessary. So we're going to go into Q&A, and Sarah will read from the questions that were submitted so that our panelists can respond.
Great, thanks, Monica, and thanks, panelists. Great presentation. We've had a lot of great questions coming in. The first one is to the CoCM team and Elisa Peterson around percentage of appointments that happen kind of virtually by Zoom versus in office, and what are the pros and cons regarding virtual visits, and perhaps talk to about how, if you use the behavioral health MA, if she's involved as well in those visits. So why don't we start with your team?
Okay. Yeah, I'd say about a quarter of my visits are by Zoom. Our psychiatric consultants sees about 50% of his patients by Zoom. So it's heavily used, and our MA is integral to getting those patients on so that I don't waste my time dealing with technology and she does the GAD-7 and the PHQ before I even get on. So it flows very nicely. It's actually come in handy this winter when there's snow days. So we use that quite a bit.
Does anyone else have tips on how you have done this work of the behavioral health care manager virtually, and maybe how you've split the duties up virtually too?
Hi, this is Rose. For our video visits, we have the support coordinators do a tech check. So especially for new patients, if this is their first time utilizing our platform, we want to make sure that they're able to log on as well as accept access to their video and their microphone, and kind of do all of that troubleshooting, get it out of the way so that when they connect with their care manager, everything goes smoothly and they can go right into their visit.
Great, thanks for those tips. This question comes to from Chris for the Prisma Health team. The behavioral health caseworker provides a lot of benefits. Are you finding that the collaborative care reimbursement and the improved efficiencies, reduced no-show rate fully cover the costs of this resource? Why don't we start with your team?
Sure. Chris, thanks for that question. So it does provide a lot of benefits for the practice. Number one, they're just paying for the time that our caseworkers are assigned to their practice, as well as the care manager. And for the caseworkers, that's usually divided, on a 5-day work week. If it's 2 practices, the bigger practice gets 3 days, the smaller practice gets 2. So from a financial perspective there, it saves them money. The other thing that we do that helps them is that anything that has to do with team benefits still stays within our department, because we do have that support that we have through our care management team. And from a billing perspective with collaborative care, it helps our care managers to do all of that clinical work that they need to do. So it's all of that billable time, and that's what we really want their time to be spent in, is the majority of their time to be billable time, because we do solely do just the collaborative care and integrated care codes. We don't split and carve out psychotherapy with our team because of the dynamic and the diversity that we have. So because the caseloads stay, we find 50 or more is pretty sustainable, and it actually helps to cover the team's cost as well, and that includes the caseworker.
There have been several other billing kind of finance questions come in. I guess, is anyone on this call billing for the support person's role, the behavioral health caseworker, MA, or the population coordinator role?
So at Prisma Health, we currently do not bill out the caseworkers' time and role. I don't think it's not that we can't. I think, based on what they're doing, you probably could. But we kind of roll that into the care managers. That's really just kind of the cost of the practice. They kind of know that they're just like they'd hire a front desk person or an MA or a nurse or somebody, that's what they're hiring for, right? So that's kind of how we look at it.
Great. Amy had a question that came up for the Kaiser team about how this program is maybe different or similar to integrated primary care behavioral health program, a PCBH type program. I don't know, Elisa, are you able to answer that question?
Here's my I'm sorry, can you repeat the question again?
Yeah, so wondering how this program is different or similar to your integrated primary care behavioral health program, PCBH. Do you have PCBH as well?
I'm not familiar with the PCBH. I apologize.
All right, no problem. That's that's different than collaborative care. It's just an integrated behavioral health clinician that's part of the team, usually doing just a few visits. So, right. There's a couple questions around, maybe we could talk a little bit about psychiatric consultation and a systematic caseload review process. I'd be interested too. And how do you work together as a team, as behavioral health care managers, but also as the support members in that psychiatric caseload review process and working with the psychiatric consultant? Anyone want to start off?
I can start. At Kittitas Valley Healthcare, I'm lucky to have my psychiatric consultant right here in the building. So we meet every Wednesday for an hour and review cases. The MA is not involved in that process.
Yep. So at Prisma Health, our psychiatric consultants are all remote. They're not in the practices, they're in their outpatient practices. So our care managers meet with them weekly. We carve out about 4 hours, but they're also meeting with multiple care managers at the same time. So it really gives them, I think, an opportunity for the care managers to help each other, but also be able to see different cases maybe and learn a little bit more. Our caseworkers are usually not involved in that, but what our psych consultants do is they will, and Jessica, you tell me if I'm wrong, but they'll usually route information, like they'll copy them on their consulting note just so that they're aware of, you know, what's going on. Is there anything we got to pick up as caseworkers and reach out to the patient or make sure the PCP's got that, you know, that kind of situation.
Hi, it's Rose. As a support coordinator, we work with our psych consultants when the patients are scoring higher than what our program handles. So if they need a higher level care and are open, then we can place a referral for them. And then for our care managers, we have them they meet, I believe, once a month to review maybe like special cases where they need some advice. So normally we can route a chart over to ask quick questions, but they also have that time each month to discuss in more detail specific cases.
Hi, this is Jessica Lord. I will say, as the caseworkers for Prisma Health, we will kind of remind the care managers of the ones that are become inactive or patients that become inactive to do those inactive case reviews to officially make them inactive, as well as we will also remind the care managers of any patients who have been in the program that are kind of reaching 2 years or more to review them as well, or have not been reviewed in a while.
Those are all really great ideas. For the Kaiser team, I guess there's just a question around caseload, kind of overall size, and has the employment of that support role, of Rose's role, been able to help with like expanding the size of the overall caseload?
Yeah, absolutely. I think that was one of our main goals too, was really, again, to take the administrative tasks that take away from treatment, and you know, with Rose and the support coordinators really helping with those pieces, really enabled us to be able to manage higher caseloads.
Yes, and also support coordinators, while we do get referrals for patients to enroll in the program, we also have different lists that we can outreach for patients who were newly diagnosed, and whether they got a PHQ-9 done, and if they scored 10 to 19, we can enroll them. If they didn't have their PHQ-9 completed, then we can call them to complete that and then enroll them if appropriate.
Yeah, and I think just to Rose's point, instead of, we do rely on referrals to the program, but we do also encourage our teams to go out and outreach to patients and find those patients that don't necessarily make it to our program. So we, again, just like she's mentioned, having those lists and outreaching to patients that are newly diagnosed, have PHQ-9s, that have GAD7s. So really outreaching to those patients that we really feel would benefit from our program.
Thank you. There was a quick question for Marcella, Rose, and Jessica, just about your kind of education and licensure background. Do you want to just say quickly what that is for the audience?
Oh, I can go first. I have a bachelor's with a background in psychology.
I've
And
been a
then-
certified medical assistant for 20 years. And I just recently completed my Associates of Arts degree in 2020 with the anticipation of hopefully going to nursing school.
And I have my bachelor's in human services.
Let's see, Monica, we're doing okay. Maybe one or two more questions.
Yeah, I think probably one more question we have time for.
Yeah, I know Autumn had a question earlier for the Kiditas team about the MA workflow and the workflow that you walked us through. Was that for an appointment with the behavioral health care manager or with the psychiatric?
It's actually for both. So I do the same check-in process across the board for Elisa and for Oren as well. And especially too, just verifying their medication. Sometimes, there'll be someone that's getting ready to meet with Elisa that's been prescribed something at their last appointment prior to their referral that just hasn't even started taking their medication. So that's kind of an important piece. We felt it was kind of undetermined at the beginning whether it would be treated the same, but I feel that it really does benefit it for the information that Elisa is allowed to know if someone's not taking a medication, or if something's just not really working, then it provides the opportunity, that I can reach out to the primary care physician while that patient is here seeing Elisa to see if we can get a sooner appointment or make changes as appropriate.
Thank you all for sharing your wealth of knowledge. We really appreciate it. On your screen now, you will, there are some additional resources specific to the behavioral health care manager role. So there's an introductory webinar there from APA, but there's free information on our website around job descriptions, roles, caseload guidelines. So some of the questions that you all had today. We also have online training and specific content that we could provide that specifically assists the behavioral health care manager and the additional support staff with the functions of the behavioral health care manager role and skills development. We provide free office hours, and that's on implementation, one on implementation and then one for finance, where you could bring your questions, including questions you may have had today that fit either in those categories and maybe not specifically for our three organizations today. We invite you to stay tuned for future webinars to share best practices and learn from each other. The webinar dates are set for 2023, and you can see them here, all at 10 a.m. Pacific time. Some tentative upcoming topics we're planning are pediatric collaborative care and innovations in registries. So if you and your team have been successful at any of these topics, let us know. And in the evaluation survey for this webinar, you'll be asked to make suggestions about what topics of interest there are to you. So let us hear from you. We're all stronger together. So please make sure to fill that out for us. Chrissy has put a link to the survey in the chat box. So please click the link and complete the brief survey provided around today's webinar. And we would like to thank you for attending today and learning more about how we support organizations with their implementation, including billing and finance. Feel free to reach out to us at our email address. We have partnered with all 3 organizations you heard from today on their implementation of collaborative care, and we're eager to help other practices succeed as well. Have a great rest of your day.